Good evening, everyone. The topic of our presentation is handling and processing samples for investigation in a case of endophthalmitis. I'll be presenting along with Sourav, and the session will be moderated by Dr. Janani. Special thanks to Anand sir for helping us throughout the presentation.
So we'll start our class with the following topics. So what are the samples to be collected? How to collect the samples? How to send the samples? Which are the routine microbiology tests to be performed? What if nothing grows in the culture? So first we'll discuss on the what are the samples to be collected. That's the aqueous, vitreous. It can be granuloma. It can be intraocular lens with or without the back contents. Intraocular foreign body, sutures, abscissed iris tissue, collection from vitrectomy cassette. Direct isolation of organisms possible only in liquid sample, rest only culture is possible. So how to collect the sample? First we come to AC tap. So the requirements are there should be a indirect ophthalmoscope, indirect ophthalmoscopy lens, 20D lens, proparacaine, apidin, eyelid speculum. There should be sterile cotton applicator with tuberculin syringe, 30 gauge needle, and eye patch. So this is a video depicting the method for AC tap. So after exposing the eye with the eyelid, the patient is told to look at in primary gaze and stabilizing the eye with a cotton tip applicator. 30 gauge needle is used and tangentially it is entered through the limbus obliquely over the iris, and in the area of maximum exudation the sample is collected. As you can see, from the area of maximum exudation, the sample is now aspirated. We have to make sure that the AC doesn't collapse.
This is the video depicting collection of vitreous sample. So it is done along with during vitrectomy. After fixing the ports, the infusion is checked if the view is okay, but it is not switched on. And so this patient had post repair sealed tear. So precautionary 2 sutures were taken at the site of sealed tear. And after fixing all the 3 ports, then cutter is introduced through one of the superior ports, and under direct visualization of the microscope, the sample is collected, and making sure that the globe does not turn hypotenuse and there is no sudden collapse. So till the time it is safe, we collect as much sample as possible. And simultaneously, when the one person, the assistant nurse is aspirating the sample, keep aspirating. So this was discussed in the previous class also, that vitreous tap is to be avoided, and especially in phakic non-vitrectomized eye, it is indicated usually in vitrectomized eye in case of non-resolving infection, and preferably with a 27 gauge needle. 0.2 to 0.3 ml sample at least should be taken. Then vitreous biopsy, it was depicted through that video along with the vitrectomy. 0.3 to 0.5 ml of sample should be collected. How to inoculate or send the sample to the lab? After collecting, the air is expelled from the syringe, preferably, since we have seen through a 30 gauge needle. After expelling the air, after the sample is inoculated in a broth, and also can be put on 1 drop on the agar plate. But if it is to be stored and sent to the lab the next day, usually 2 broths, liquid broths we take, the Breen infusion broth and thioglycolate broth, and 2 to 3 drops we can inoculate in the liquid sample, and then we can put the syringe into the cork and sealed it in a sterile, a larger container. And this container can be kept at 4 degrees Celsius. The broth can be kept at room temperature.
This is a slide we have kept to show how to raise the lab form. After selecting the patient and signing in, we have to go to the lab form column. Then there are specific codes depicting for the gram stain, for the KOH and chalcophore stain, culture for bacteria. So after selecting the code, then we have to select the specimen name, like if we are sending aqueous aspirate or vitreous aspirate. And if we are sending other samples like intraocular lens also, there is a specific, we have to write in the specimen name that the IOL, and we have to select the test name accordingly. This is an article published in the Australian Medical Journal. It supports the fact that vitrectomy fluid appears to be the best sample for culture from clinically diagnosed endophthalmitis cases.
So what are the routine microbiological tests that was done? The common stains used a gram stain to differentiate gram-positive, gram-negative organism, acid-fast stain for mycobacteria and nocardia, KOH mount for fungal pathogen, calcofluor mount for fluorescent, it's a fluorescent stain for fungi, microsporidia and acanthamoeba. And what are the common culture medias? So for solid media, we have blood agar, which is for aerobic bacteria, chocolate agar for solid media for certain fastidious organism. It is incubated in 5% carbon dioxide aerobically. Then SDA is a selective media for detection of fungi. Then thioglycolate and BHI, these are two liquid medias. So BHI is for aerobic bacteria and the thioglycolate is for anaerobic organism. Brucella blood agar is also, it's a solid media for anaerobic bacteria. These are the images for common liquid and solid media used in our lab. So 1 drop inoculated in the center of the agar media and into the broth, and inoculation of the media is to be done first. And like I told, sample collected in odd hours should be kept at room temperature, and that sterile container, that corked tube should be kept at 4 degrees Celsius compartment. These are the common incubators in our lab. First one is the anaerobic incubator. Second one is the carbon dioxide incubator for fastidious organism, and third one is aerobic incubator. Sir, you wanted to add something?
Yeah, if you can go back to the previous slide. So normally once before that, yeah.
Yes.
Okay, so the first thing which we do when we do a cytospin for the direct smears. So basically it's a small centrifuge which centrifuges your sample onto a slide, the same principle of centrifugation. And so gram stain is first to identify. Once we identify the bacteria, we can say if it is gram positive or gram negative. And we don't do acid fast for every vitreous, only if it is suspected we do an acid fast stain.
Yes, sir.
And then we do a KOH combined with a calcofluor white. So the job of the KOH is to digest all the human tissue, and fungal cells are resistant to potassium hydroxide. And calcofluor is a stain which is stains cellulose and chitin in the fungal cell wall. So they fluoresce in a dark background.
Okay, sir.
And so then the other media are fine. And now we also use the BACTEC, which is a blood culture system, which has got an indicator to show if bacteria are growing. So and because it's got a shaking system, we can find out if the bacteria are growing quite early compared to the normal visualization of turbidity.
Yes, sir. We have image for BACTEC and VITEC also, sir, we have taken.
Yeah.
So this is our biochemical method for organism identification and antibiotic sensitivity. So this is the centrifuge machine in our lab. So any diluted sample is centrifuged at the speed of 2500 rotation per minute for 15 minutes, and then sediments are collected and processed. IOL can be directly put into BHI broth, and for Candida albicans, non-albicans, we have germ tube test, and for filamentous fungi, the microscopic examination for identifying the colony morphology.
So for direct isolation of organisms, there is gram staining, KOH mount, there are other fungal stains, and there is acid fast staining.
So here I'd like to point out that isolation is only for culture. Here you mean the direct identification.
Yeah.
The isolation actually always means culture.
Okay, sir.
Fast growing organisms in 1 to 2 days. The anaerobes, Propionibacterium acnes, atypical mycobacteria, nocardia, and fungus. It takes around 3 to 4 days. Maximum days before declaring a culture to be negative is around 12 days.
These are the representative images for the common organism. First one is the gram-positive cocci. Then next is the gram-negative bacilli, gram-positive bacilli, the septate fungi and yeast. These are growth in culture media. The staph epidermidis, Pseudomonas aeruginosa, Bacillus species, Candida albicans, Aspergillus, and nocardia. These are the common pathogens which are associated with the different conditions for endophthalmitis. We had discussed this in last session also.
So these are the common contaminants. So for the staph epidermidis, which is found in the skin flora, it can be pathogenic in post-operative endophthalmitis. Propionibacterium acnes, they are anaerobic skin commensals. Bacillus species, these are environmental organisms, but Bacillus cereus is common pathogenic in traumatic endophthalmitis. And we have the Micrococcus species and yeast. So what are the shortcomings of TAP?
So I'll just like to
Yeah.
come in. So here, unlike in other samples like blood where septicemia is suspected, where staph epidermidis can be a skin commensal and it can be a contaminant, the common contaminants also tend to be the most common causes of endophthalmitis. So it's so that is why, like Staphylococcus epidermidis, Propionibacterium, they are one of the most common causes of endophthalmitis. So you cannot always call it. So we have a criteria. Normally we take that it should grow on more than one medium, or we correlate with the direct smear and then report if it is significant or not.
So coming to shortcomings of TAP, contaminants or false positive organisms, as we had discussed. Non-surgical biopsies, when there is inadequate sample volumes, it's called dry TAP. If there is delay in testing, samples retrieved after antimicrobial administration, and when there is insufficient and suboptimal results of standard testing.
So what is the role of polymerase chain reaction in sample processing? So we have different type of molecular techniques like quantitative PCR or real-time PCR. It is specific custom primers are used, and for targeted amplification and quantification, it takes around 2 to 3 hours. These are the turnaround time that is given in the last column. Then pan bacterial, pan fungal, which we usually raise. It uses a universal 16S rRNA primer sequence, and useful when cultures are negative or empiric treatment fails. Turnaround time is 2 to 3 days. But then we have multi-mono PCR primers, which are only very common 20 bacterial pathogens it detects. Within 90 minutes is the turnaround time. Then targeted high throughput sequence, or this is next generation sequencing, selectively amplifies the pathogenic genomic regions using panels of known genes. It takes 2 to 8 hours. Then we have matrix assisted laser desorption ionization time of flight mass spectrometry, also called as MALDI-TOF MS. Its proteomic fingerprints is matched with, so first the cell extract is split by the ionization technique, and then those cell extract are studied, and the sequence is compared with the already existing database, and the turnaround time is 3 to 5 days.
So the reason why we don't use a multiplex PCR which targets a small group of organisms is the diversity of organisms which cause endophthalmitis doesn't cover, because we can get a range of organisms. So till now there is no commercial kit available which detects a specific set of organisms still available. So we do an in-house PCR which broadly detects whether it's bacteria or fungi, and then depending on the product, we can sequence the product to find out what it is if needed. And the turnaround time is not 2 to 3 days. Actually, the extraction takes about 1 or 2 hours to release the DNA from the organism. The PCR takes about 4 hours, and then we have a post-amplify. So it's less than 24 hours we can give the result. And then MALDI-TOF is just like you have a DNA signature, every organism has got a protein signature. And so this MALDI-TOF will help detect what is the ID of the organism. And so that
To
actually
pinpoint
takes,
the species.
it can tell. So all you need to do is once you isolate the organism, you lyse it and see the protein signature. And so that actually takes only 20 minutes. So
Okay,
some
sir.
of the labs have got it. It's a very expensive machine, but it's not like 3 to 5 days.
Okay, sir. So this is one of the paper published which summarizes that out of their 50 endophthalmitis samples, 19 were culture positive and nested PCR detected pathogen in an additional 11 culture negative cases. So total diagnostic detection raised up to 38% for culture alone and 60% for culture and PCR. So PCR helps in getting to the diagnosis. What is the difference between means how to compare the PCR and culture reports? So PCR can be highly false positive in bacterial infection. So for bacteria, culture is best, and it can be high false negative in fungal infection. So direct isolation is best for fungal infection. PCR sensitivity is 66 to 95%. Culture is 30 to 60% only. Turnaround time 1 to 3 hours for real time, and for pan fungal pan bacterial is 2 to 3. Again, sir is said 24 hours. Then culture is 2 to 14 days. We observe till 14 days before declaring it negative. PCR can detect both species specific and broad range organism, and culture is only viable organism. Higher cost for PCR and lower cost and contamination is also less in culture.
So what if nothing grows in the culture? We have to start with empirical intravitreal antibiotics or antifungals immediately. Repeat aqueous tap, and we have to send for either aerobic, anaerobic, fungal, mycobacterial, panfungal, and bacterial PCR and viral PCR. We have to consider partial vitrectomy or vitreous lavage to reduce the microbial load and improve the drug penetration. Then we can monitor the response to treatment, and if there is improvement within 40 to 72 hours, it supports an infectious cause, and even if the lab reports are negative in these cases. We have to reassess the diagnosis if there is no improvement, and ruling out TAS, autoimmune uveitis, and masculine syndrome.
So follow-up action after the diagnostic testing. Initial culture results are positive. Then we go about sensitivity and accordingly guided treatment. If the cultures are negative, we can go for PCR or next generation sequencing and treat based on the identified pathogen. If that is also negative, if nothing is growing in culture, no results from PCR, consider repeat sampling, expand the testing, and or you reassess the diagnosis. So the key take-home message: collect as early as possible without contamination, inoculate early. Communication with the microbiologist is the key. And if there is no growth, no response, you can try resampling or vitreous lavage. And PCR is only an ancillary test. It does not investigate for complete. Investigation should not be relied on it completely. These are my acknowledgements. Thank you.
I'll just mention a couple of things. So one of the reasons for like even in our setup, the culture negativity in vitreous is almost like 60% we get culture negativity. So the reasons for it is, one thing is in general ocular samples are in small volumes and the number of load of bacteria will be very less. And other thing is often organisms tend to be sequestered. So they'll not be always floating in the vitreous and they'll be sequestered. So the sampling error could be there. So that could be one of the reasons. And the prior antibiotic therapy also is one of the reasons for
Getting a
culture
negative.
negativity. And so culture is still the gold standard. Culture can do a lot of things which PCR cannot do. Like you cannot get antibiotic resistance with PCR still. So culture is still the gold standard. And PCR has its limitations, like you said, false positivity, because we are using universal bacterial primers. Still, false positivity in studies have shown about 15 to 20% false positivity in bacterial. Fungal sometimes it's difficult to lyse the cell, so it gives some false negativity sometimes. And PCR again, because of the diversity in endophthalmitis, it's still quite challenging to use specific primers.
Yes.
So good evening, everyone. We'll be continuing with the SR capsules on endophthalmitis. The next session is on the agents, routes, and protocols. Myself is Dr. Sarjak, and here with me is Dr. Divya. We'll be presenting on this topic, and the session is moderated by Dr. Arkaprava Pradhan, sir. So to start with, what are the routes of drug administration we commonly see in ophthalmological practice, especially in case of endophthalmitis? We can give the agents via topical administration, intravitreal injection, or systemic like oral and intravenous. Periocular injection we rarely see in our clinical practice. So the common antibiotic and antifungal agents, as we all know from our clinical practice and our knowledge of microbiology and pathology, pharmacology, the antibiotics commonly used are ceftazidime, which intravitreal dose especially is in 0.1 milliliter of 2.25 of milligram. It can be given intravenously and also topically also. Vancomycin is another common agent that we use 1 milligram per 0.1 milliliter. Apart from that, other agents such as clindamycin, ciprofloxacin, moxifloxacin and amikacin can be given in special situations based on the isolation of the organism in culture or other methods. Amikacin usually was proposed to be given in endophthalmitis vitrectomy study, but due to the macular toxicity is now discontinued. So the common antifungal agents can be divided into polyenes like amphotericin B and natamycin, the triazoles such as voriconazole, the echinocandins such as caspofungin, and fluconazole. All these drugs use of the drugs depend on the sensitivity of the fungus grown in the culture. The intravitreal dose is again in 0.1 milliliter of 5 microgram for amphotericin B, 100 microgram for voriconazole, and 50 microgram for caspofungin. Topically also they should be given simultaneously with the intravitreal doses, and systemic doses also should be started in case of antifungal in contrast to the antibiotic agents. All these drugs are toxic in one way or the other, especially in kidney and liver. So simultaneous monitoring of the renal and kidney and the liver function test is required. In special cases such as voriconazole and vancomycin, when it is affected by the metabolic variations in the liver, the cytochrome P450 enzymes, therapeutic dose monitoring is also recommended in initial phases of the drug therapy. So these are the inherent differences between managing bacterial and fungal endophthalmitis. So these are modified from over the years, starting from the endophthalmitis vitrectomy study. Focusing on the intravitreal injection part, in post-cataract surgery, bacterial endophthalmitis, we usually give combination of antibiotics. One takes care of the gram-positive organism and the other one takes care of the gram-negative. And inherently it should be repeated within 42 to 72 hours if needed. In contrast to antifungal agent, we usually use a single single agent, and intravitreal injection is repeated always irrespective of the clinical response. Topical antimicrobials can be given in both situations, and corticosteroids again only to be given in bacterial endophthalmitis. So what is an ideal intravitreal agent? So it should be effective against the virulent organism. It should be non-toxic to the retina in the bactericidal doses. And appropriate half-life in vitreous cavity should be there, especially inflammatory pathology such as endophthalmitis. The half-life usually is longer compared to a normal eye because of the blood-retinal barrier, which is the elimination of the intravitreal agents is reduced in inflammatory eyes. And it should be easily available and cost-effective. What is the role of systemic antimicrobials, intravenous or oral? So especially in cases of endogenous endophthalmitis, usually of fungal etiology, it should be started empirically. In case of severe acute purulent postoperative endophthalmitis also, it should be started irrespective of the isolation of the organism. Post-traumatic endophthalmitis also it is advocated by some groups and some studies. And ocular inflammation, as I said, increases the drug permeability across the blood-retinal barrier. So I'll hand it over to Dr. Divya.
Last point you said, can you go back to the previous slide? Yeah, no. So you said ocular inflammation increases the drug permeability. So what does it do to the half-life then?
So it's usually the systemic agents that we are giving.
Yeah, so the intravitreal drug actually clears faster because of inflammation. So if you supplement it with either a topical or an intravenous is only when the concentration, otherwise by pure definition an intravitreal agent is cleared up faster in an inflammation. because of this reason.
So I'll be presenting the cases. So first case is a 64-year-old man. He presented with complaints of pain and redness in the right eye since 5 days of presentation, and he underwent cataract surgery 5 days back elsewhere. So in that hospital, he consulted the next day, and he was given intravitreal peptides, vancomycin, and dexamethasone. Then he presented here with a corneal ring ulcer with total corneal epithelial defect with iris in the wound. So this was the ultrasound which was done at the presentation, showing the vitreous cavity full of echoes. So as soon as the patient presented, he underwent IOL removal and vitrectomy was done. At the same sitting, injection Vanco, Septa and Deca were given, and vitreous aspirate was sent for PCR. And following that, there is a second dose which was given in a 1-day gap. Injection vancomycin and dexamethasone were given. So this was a vitrectomized eye then. Then there was no improvement, and the vitreous aspirate showed that it is a methicillin resistant Staphylococcus epidermidis. So as there was no improvement, in total he took 3 doses, including the first dose in the other hospital. So as there was no improvement, so the drug was switched to injection linezolid, and 5 doses were given. Daily regimen was given in this, and IV linezolid 600 mg BD was given for 5 days. This was followed by oral ciprofloxacin 500 mg BD. So after this 5 doses of intravitreal linezolid, the vitreous was seemed to be clearing, and the echoes have decreased, and the fibrous condensation and decrease in the ring ulceration was also seen. So coming to the second case, this is a 30-year-old male patient. He's a one-eyed patient with no significant systemic history, but he underwent a PK with ECC and IOL on 7th, and on post-operative day 7, he was presented with blurring of vision. So then the donor button was sent for examination, and it showed Candida non-albicans as the organism, and AC tab was taken as soon as the patient was presented with the same symptoms, and Candida non-albicans, the same organism, was isolated, which was sensitive to voriconazole and amphotericin B. Empirically, we start the intravitreal vancomycin, ceftazidime and voriconazole even before after the tab was given, and there was no response. So injection amphotericin B was given first dose, and repeated ultrasound was done, and that ultrasound has shown that the choroidal thickness has increased, so it has become 1.42 millimeters. And after that, vitrectomy and second dose of amphotericin B was given. So that was followed by 6 more doses of injection amphotericin B in that vitrectomized eye. So following this, this was after the first injection of amphotericin B with the trace hypopion. This is the slit lamp picture. So this picture was before the vitrectomy, and this ultrasound was also before the vitrectomy. This this picture is showing that it is after 3 weeks after the patient was given these injections, and it showed that the fibrin was cleared and the graft has become clear, and fundus is visible. So this is the case 3, where the female is a 40-year-old female. She is actually having a duodenal jejunal stunting with hydronephrosis. She had ocular symptoms in both the eyes since the time she had discharged from the hospital. So the presenting vision of right eye was counting finger close to face, and left eye was 6/36. Then they have sent for blood and urine cultures, and they were the fundus was also hazy in that time, and AC had more reaction compared to the left eye. Right eye was having more reaction compared to the left eye, and they have decided for doing vitrectomy in the right eye. So when the vitreous aspirate was collected and sent for examination, yeast organism was obtained, and urine culture was Klebsiella positive. So both eyes injection intravitreal meropenem with voriconazole was given, and Candida albicans was isolated, and this is resistant to voriconazole and fluconazole. So this was the picture of the patient, after the injection, first injection, and after she came. So these are the serial ultrasounds after the patient were given the injections, but the vitreous echoes were seemed to be decreasing. And next, what happened was patient was finding there is a worsening of vision in the left eye. So now left eye vitrectomy was planned and left eye vitrectomy was done. Still, the patient did not find any improvement. So, injection intravitreal caspofungin with amphotericin was given alternate day regimen for 3 doses. Means 3 days alternately for 6 days. Injection caspofungin and amphotericin were given, and the response was good. And it was continued for 2 more injections of caspofungin. So this was the fundus of the left eye. When the patient underwent vitrectomy and subsequently injection intravitreal caspofungin and amphotericin were given. So after the 3 day 3 doses alternate regimen, this was the second fundus picture. And after the complete dose of caspofungin, the fundus was clearing. Vitreous was clearing and the fundus was seen. So these are the 3 cases, sir, where we have switched the antibiotics and the antifungals. And the response was better.
So now coming on to the recommendation, when to start the antibiotic intravitreal antimicrobial therapy, it is indicated in any case with clinical suspicion of endophthalmitis. It should be started at the outset. If vision is more than hand movements, this is based on the EVS recommendation. If you are in a setup where the surgical setup is not available, to by the time till a VR surgical facilities are available, you should give intravitreal empirical therapy, and also at the completion of the vitrectomy, it should be given. So the switching and stopping protocol, again, it depends on the clinical outcome of the first empirical therapy, and also on the isolation of the microbiological tests. So if the gram-positive organisms are there and it is resistant to vancomycin after giving 2 consecutive injections, we can switch to special antimicrobial agents like linezolid, daptomycin, which are also found to be effective. In gram-negative organisms, faster decision making is required because clinical worsening is very rapid. So in cases which are resistant to ceftazidime, imipenem and fluoroquinolones are also highly effective. And in case of fungus which are resistant to voriconazoles, it should be switched to amphotericin B. And later, if again the yeast organism, like in the third case, if it's resistant to amphotericin B, it should be switched to caspofungin. So these are the final recommendation which we found in some studies, and it is a proposed modification of the EVS protocol. So what should be done is in the outset of the clinical suspicion, a vitreous tap with injection is to be performed, usually with intravitreal vancomycin and ceftazidime in the given dose. Simultaneously, oral antibiotics like moxifloxacin or linezolid should be started for a 5 days complete course. Assess clinically. If the response is there, it should be repeated. If vitreous debris are still there after the resolution, late vitrectomy can be performed. If the poor response is there, and if you already isolated gotten the sample and isolated the organism, you can switch it to whatever antibiotic agent is sensitive to that organism. And again, if further deterioration is there, urgent vitrectomy should be performed within 48 hours of clinical worsening. The treatment usually continues till 2 weeks if intravenous therapy is also to be started. And in case of clinically suspected fungal endophthalmitis, again empirical intravitreal therapy should be given. Intravitreal tap or biopsy also should be performed. In case of high suspicion, voriconazole is the first agent to be given. And in case of microbiological confirmation of either candida or aspergillus, accordingly oral and intravitreal both therapy should be continued. Usually the systemic therapy of voriconazole is around 400 milligrams for the first 2 doses. After that, it should be switched to 300 milligram along with the therapeutic dose monitoring for 4 to 6 weeks. And in case of aspergillus, vozole or amphotericin B, either of them can be administered. In case of fungal endophthalmitis, vitrectomy should be considered in patients who present with severe infection, severe vitritis, or worsening or non-improvement after 2 intravitreal injections. So does the EVS recommendation still hold up today? Some might differ and some might agree. Today, usually the practices of single dose systemic antibiotics, which can be optional. The treatment is usually outpatient. Intravitreal Venco and ceftazidime are given. Optional intravitreal steroids. The next session will discuss about the role of intravitreal steroids. Subconjunctival medication we rarely give. Topical fluoroquinolones and other topical antifungals to be started. And smaller gauge vitrectomy is now preferred compared to the previous era. And the role of systemic steroid is still questionable. A special consideration should be done in pediatric population, which is outside the purview of this class. Intrabag injection can be given for indolent fungal P. acnes infection. Unconventional sampling is also preferred in cases where isolation is not obtained after one or more attempts. Culture or PCR negative cases are polymicrobial, so in that case, longer treatment is usually necessary. And higher or special anti-infective agents in drug-resistant strains and gram-negative organisms are to be applied. So, what are the take-home messages from this class?
So the take-home messages are empirical intravitreal antibiotics or antifungals are usually injected with clinical suspicion even before the proper or definitive diagnosis is made. So monitor daily response for the treatment. We have to see whether there is a worsening in inflammation, there is any declining in the vision, or is there any increase in the pain. So we have to repeat injections based on this. And we have to switch to alternate drugs in case of no response or any worsening or antibiotic resistance which is on rise now. So systemic antibiotics and antifungals, they have to be started in endogenous endophthalmitis for maintaining the therapeutic concentrations, because as Sir said now that the antifungals and intravitreal drugs have lesser half-life, and because to maintain their therapeutic dosage for their action, we have to give daily intravitreal injections, or they have to be supported by the systemic antibiotics and antifungals. So we have to take opinion from ID specialist for physician for appropriate management, and we have to monitor the LFT and RFT in cases of periodic intervals in case if we are giving antifungals, because their route of excretion is through kidney and liver.
Acknowledgements to Dr. KP sir and Dr. Jason ma'am for the cases. Thank you so much.
Okay, I just have one quick comment about this empirical antifungal injection that you have written. So empirical antifungal intravitreal is, as far as possible, should be avoided, because at least some KOH confirmation of fungus should be there, because antifungals are highly toxic. So you would not like to subject a patient to antifungal if there is no fungus in the in the eye. So at least some KOH confirmation, or if you have a culture from some other body fluid which tells you that there is fungus, that's fine. But giving empirical antifungals as far as possible should be avoided. So in situation where there is absolutely no other go, then probably you are justified. But to begin with, I think you should at least try to get some fungus on the...
Ma'am, if the patient already has some infection, if they have already fungus infection and they are presenting with endophthalmitis, so in that case, KOH is done and then we give the injections, or we can
No,
give
if the patient already has a fungal infection, known to have fungal infection, then it is fine. Then you presume the endophthalmitis to be fungal endophthalmitis. Yes. But if the patient is presenting with endoph and you do not know whether any, the organism, causative organism, in that situation, efforts should be made to look for, fungus in all possible ways to determine whether there is fungus or no. Last class you discussed about that beta D-glucan and all that.
Yes,
no?
ma'am.
Just a comment, nicely done, but I think last week also we discussed that more than... How many of you have seen a vitreous tap happening in the OPD? Anyone? Presenters? Because you presented, right? So I think the idea is we try and present what we do here, right? Neither did we have a demonstration in the first presentation how to take a vitreous tap. So I think we need to mention the role of aqueous tap in endophthalmitis, because that is what we do here. We don't stick a 30 gauge needle through pars plana in the OPD, right?
Yeah.
So I think at some point we need to mention what we do. If you're doing it, it's well and good. Otherwise, here, if someone has to look at the presentation, that means we are not treating endophthalmitis like we should.
Yeah, only that means about the route of administration. There's they already you have mentioned that, but there are one point to make. Like if this is a aphakic patient, we avoid to go through the pars plana route always. So we go through the AC route, means and intracamerally. And if there is post PK endophthalmitis, there was one case of post PK endophthalmitis. So in those cases, if it is aphakic, so in that situation, we avoid going through the corneal button. So these are the 2 points in like how to inject like, route of antibiotic. And yeah, we have chosen 3 cases. Like one was the bacterial endophthalmitis, and which was resistant to vancomycin and given linezolid. And second case was post PK endophthalmitis, and this corneal button was grown fungus, and how we manage that case. And another one we have chosen like this fungal endophthalmitis, endogenous endophthalmitis. So this vitreous tab we usually don't do. So we have to we do AC tab, and then we decide about the send for gram and QH, and then we can inject intravitreal antibiotic. But if we do it if we do vitreous biopsy or vitrectomy, that should be in the operation theater, not in the in OPD we don't do any vitreous tab.
This comment that you made about increased choroidal thickness leading you to vitrectomy, I don't think is the correct thing. The indication for vitrectomy would be an increase in the vitreous
patient
locus.
is not responding and patient is feeling that.
No,
yes,
so I understood, but when you are presenting it, you can say that there was an increased choroidal thickness and increase in the vitreous inflammation, and that's why the vitrectomy. You won't do a vitrectomy only if there is a choroidal thickening and the vitreous is otherwise clear. Can you go to your very first slide? Yeah, I think the direction of the periocular injection is not correct.
It is directly. That is why I think we don't give it this.
No, meaning orbit की तरफ से जा रहा है.
It's just a pictorial representation from the article. I'm sorry for the
When you
inaccuracy.
quote an article, so this is not the way to put the reference. You don't know when was it published. No idea you have, right? You should always put the year and the correct.
The author names have been cut, I think. Yeah.
Yeah, when you cut, you need to have the essential details.
Yeah, sure.
How do you decide how often to repeat an intravitreal antibiotic? What are the factors?
First, we look at the.
Do you give daily or do you give alternate day?
If the patient is having AC reaction and hypopion at presentation, we look whether that hypopion is decreasing or is it stable, or whether that is increasing. That
Okay, clinical response one. What is it?
And
so second is ultrasound we do, and
so that's what clinical response means. Clinical and imaging both. The response
the virulence
to the
of the
intravitreal,
organism
okay.
also.
Sorry?
If the organism is known, then the virulence of the organism also decides.
That is to decide which antibiotic to give.
Yeah.
I'm asking the frequency of injection.
vitrectomized
Yeah.
or non-vitrectomized.
Non-vitrectomized and vitrectomized eyes can differ.
Okay.
So faster clearing of drugs, so frequency will be.
Okay. Anything else?
Respected consultants, my dear fellows and PGs, a very good evening to one and all present here. We are here to present on the topic of role of steroids in endophthalmitis, and our guide is Dr. VJP sir. There always exists a controversy in the use of intravitreal or systemic steroids in endophthalmitis. First is the exacerbation of a fungal infection, or in cases where there is a mixed bacterial or fungal infections, do we use intravitreal steroids or systemic steroids? Steroids are known to inhibit the inflammatory cascade, which is beneficial in improving the outcome of the inflammation, but it also prevents the neutrophil sequestration, which is important for eliminating the infectious organism. And we all have the question of when is it safe to give intravitreal steroids in endophthalmitis? When do we initiate steroids? Whether an early initiation is helpful or a delayed initiation is safe? And when do we stop steroids? So the role of steroids in endophthalmitis, it is proven to combat the severe inflammation and in turn damage to the neurosensory retina. It preserves the anatomical integrity on initiation, and it helps to prevent the need for an evisceration, and it helps to shorten the overall disease course. And intravitreal steroids are beneficial when oral steroids are contraindicated. There are two schools of thought on the visual outcome after initiation of steroids, but most studies say that there is no independent effect on the visual outcome with steroids. And early initiation of corticosteroids under the cover of intravitreal antibiotics helps to prevent a concurrent inflammation, but a delayed initiation with an initial cover of intravitreal antibiotics helps to prevent a flare-up, and it is always safe when the etiology is unknown. There are limitations of intravitreal and systemic steroids. Dexamethasone has a half-life of only 3 hours, and it is eliminated within 2 days, and hence it does not provide a prolonged beneficial effect, but it is helpful when the etiology is unknown. And it does not provide additional visual benefits as we had discussed, and there is a need for close follow-up in cases where the culture is negative. We have to look for progression clinically, and there have been studies which have shown that if the intravitreal antibiotic is responsive, but we are adding steroids, then it has, even in the absence of steroids, the outcome is found to be improving. But if we are giving resistant intravitreal antibiotic, even with an optimum dose of steroids, we have studies have shown that the outcome is found to be poor. So steroids are just adjuvants to intravitreal antibiotics. The routes of administration are, they can be given posterior subtenon and suprachoroidal are mostly given for uveitic macular edema, whereas in endophthalmitis, intravitreal, topical and oral steroids are given. The dose for oral is 1 milligram per kg body weight and a tapering dose. Intravitreal dexamethasone is given in a dose of 0.4 milligram and 0.1 ml. The vial of 2 ml contains 8 milligram and 0.1 ml can be directly taken. And triamcinolone acetonide, it is less preferred, and it is 4 milligram in 1.1 ml dosage, where the vial is 40 milligram per ml vial, where directly 0.1 ml is taken. The half-life of dexamethasone is lower, whereas it is higher in triamcinolone. For dexamethasone, it's about 3 hours, whereas for triamcinolone, it is for about 18 days. And the side effects, it is known to increase the intraocular pressure, which has to be monitored. And for tricot, triamcinolone, there have been some studies which have shown macular infarction also to occur.
Very good evening all. So we'll be discussing a couple of cases where steroids have proven to be helpful in cases of endophthalmitis. So this is a case, 63-year-old male who presented with chief complaints of diminution of vision in the left eye 2 weeks prior to the presentation. Systemically, he had a thyroid disorder for which he had undergone a thyroidectomy a couple of years prior to presentation. The best corrected visual acuity in the right eye was 6.6 and 6, and the left eye was counting fingers at 50 centimeters, and near vision was in 36. Rho plus was negative in both the eyes. The intraocular pressure in the right eye was 16 and left eye was elevated at 33 millimeters of mercury. Anterior segment, right eye was within normal limits. Left eye showed anterior chamber cells along with mid-dilated, sluggish and slow tonic pupil. Right eye was a pseudophakic eye and left was an aphakic eye. There was no apparent history of any trauma or steroid use. Retina of both the eyes was within normal limits. There was no peripheral lesions, but the left eye had an inferior subluxated IOL. So patient was started on IOP lowering medications, and once the IOP was controlled, patient was posted for lens with SFIOL. The immediate post-op period for this patient was uneventful until day 13, when the patient presented with complaints of pain for the preceding 3 days. The patient was on tapering course of Predfort. He was using it 10 times a day. The vision was hand movements at this point of time, and the anterior segment showed conjunctival congestion along with corneal stromal edema, hypopion, and the SF5L was in situ, in place. At this point of time, we went ahead and did an ultrasound, and though not very clearly seen, eyeball reverberations were present. We can see in the vitreous cavity there is low to moderately reflective dot and clump echoes along with moderately reflective membranous echoes as well. We went ahead and did an AC tap and sent this aspirate for Graham's KOH smear, culture, and PCR. The immediate smears came out to be negative, and first dose of intravitreal vancomycin plus ceftazidime plus dexamethasone was given. Patient was the steroids or topical steroids were hiked up to 12 times a day, and topical antibiotics were also started at this point of time. This is a chart which is just showing the overall progression of the course of endophthalmitis in this patient. At the day of presentation, since the smears were negative, we didn't go ahead and admit the patient. The patient was reviewed back the next day when the 24-hour culture revealed gram-negative bacilli, and the PCR also turned out to be positive for U bacteria. So the patient was admitted at this point of time, and injection IV Taxim was started 1 gram twice a day, and oral steroids were also started at 60 milligrams per day after getting the physician clearance. So the patient was admitted for a total of 6 days. 3 doses of vancomycin plus ceftazidime plus dexamethasone were given, and 5 days of intravenous Taxim was also given. The 48-hour culture showed Pseudomonas aeruginosus, and this was sensitive to all the antibiotics except vancomycin. This was the 3rd case of vancomycin resistance that we had gotten here. So from 3rd day onwards, we put the patient only on ceftazidime plus dexamethasone intravitreal. After the 5 days of intravenous antibiotics, the patient was shifted on to oral Ciplox 500 milligrams twice a day for 1 week. All this time, the oral steroids were continued for the patient. The hypopion was noted to start regressing from day 6 onwards, and the fibrin started to fibrin also started reducing since 10th day onwards. At 4-month presentation, 4 months from presentation, this was the vision of the patient had improved to 618. Near vision was N18. The pressures had built up to 12 millimeters of mercury. Anterior segment was almost clear with few dilated perilimbal vessels and fibrin strands. The fundus view was clear, retina was attached, and no exudates were noted. On OCT, a very thin ERM was noted with minimal subfoveal SRF. So the patient, because of subclinical inflammation, was started on lotepred weekly tapering dose with nipafenec eye drops. So just to summarize the serial ultrasounds of this patient when the patient had acute endophthalmitis, over a course of days, as we can see, the dot echoes, the echoes have gone on reducing, and the vitreous, the membranous echoes have started consolidating. And by day 10 and day 17, we can see the vitreous, the echoes have almost reduced to none, but the clump echoes, the membranous echoes have consolidated and just settled inferior to the disc as a clump echo. Anterior segment slit lamp photographs just to show the progression over the days. The hypopion and the fibrin have reduced over first 4-5 days, and by month 4 it's almost a clear anterior segment. Up to day 7 of the presentation, there was no fundus view, but by day 10 the view had improved. We had taken an optos image. This image shows the left eye where the disc was hazily seen. The vessels up to the 2nd order were also seen. And by day 17, when the patient was only on oral steroids, the fundus view had further improved, and we could see vessels up to the third order as well. So this shows the importance, the benefit of steroids in a culture positive end of case. Case 2 was a 66-year-old male. Systemically, he was a hypothyroid, presented with chief complaints of diminution of vision with mild pain and floaters for the past 1 day. He had undergone a recent phaco-IOL with vitrectomy and ARM removal a couple of days ago. So the patient was on Predfort 12 times a day, topical, and the best corrected visual acuity at presentation was hand movements, which preoperatively before the ARM removal was 612. The left eye was 6.6 and 6. Anterior segment showed 1.5 millimeters of hypopyon along with fibrin and AC cells of +4. The PCIOL was also encapsulated within the fibrin. There was no view of the fundus at this point of time, so we went ahead and did an ultrasound of the right eye, where plenty of vitreous echoes were noted, along with an attached retina, choroidal thickening, and we can see the peripheral uncut vitreous gel. AC tap was taken at this point of time, and gram and KH smears showed no growth. So intravitreal vancomycin plus ceftazidime plus dexamethasone first dose was given at this point of time. The patient was not admitted. Over a course of days, the first day, the culture, 24-hour culture returned negative, and so the patient was just observed, and after proper physician clearance, oral steroids were also started and IV antibiotics were also started. I'm sorry, the patient was admitted at this point of time for 5 days. On day 3, there was no growth. That is, after 48 hours of culture, there still was no growth from the aqueous aspirate, and second dose of vancomycin plus ceftazidime plus dexamethasone was given at this point. PCR tests also returned to be negative. Over a period of 5 days, the fundus view slowly became better. There was a hazy view. The disc was very hazily seen. By this point, we had given 3 doses of Vanco plus Cefta plus Dexa. The patient was on oral steroids. By day 6, the hypopyon started reducing, and by day 7, the fibrin had almost resolved up to a streak fibrin. By day 24, the best corrected visual acuity had improved to 612. Clinically, the fibrin and the hypopyon had completely resolved, and the fundus, there was a very good view of the retina with disc and macula appearing normal. The third order vessels were very clearly visible, and inferiorly a few nummular pre-retinal exudates were seen. So to comment on the serial USGs of this patient, the patient, as we can see, the dot echoes and the clump echoes progressively reduced over time, but the membranous echoes by day 3 gave an impression of an retinal detachment. But since there was a good after movements and the patient was responding well clinically, we decided to just observe the patient at this point of time, and by day 5, the membranous echoes had almost resolved, but serous choroidal detachment was noted. Since the patient was already on oral steroids, we kept on observing this patient, and slowly over a period of time, the serous choroidal detachment also reduced. Just to show the day 4 and day 24 anterior segment photo of the corneal edema had cleared, the hypopyon and the fibrin had resolved, and the eye looked very quiet by day 24.
So what are the guidelines about steroids initiation in endophthalmitis? We can give intravitreal dexamethasone until it is proven to be fungal on AC or vitreous tap, which grows in either KOH or on culture. We have to avoid intravitreal steroids if there is a high degree of clinical suspicion of fungal etiology. We can initiate steroids under the cover of antibiotics, and we can stop steroids once we find clinical improvement and once the inflammation reduces. Steroids are only adjuvants to intravitreal antibiotics in endophthalmitis, and clinical response is mainly determined by the efficacy of the appropriate intravitreal antibiotic. So close follow-up and keen vigilance is important. We have to look for worsening in case of cases where a fungal or a mixed fungal and bacterial etiology is present. We would like to thank Dr. VJP sir and Dr. CR sir for their guidance. Thank you.
So that second case is my case, and that's the importance of doing ultrasound. Yeah, and so ultrasound, you have to be very careful in interpreting those images. So at one point I felt that looks like a nardi, but then because I was also checking the intraocular pressure and the anti-segment inflammation. So that corroborated that if it's a rheumatogenic retinal detachment, usually you will have the RD progressing extremely fast in a case where the vitrectomy was already done. That wasn't happening, and the intraocular pressure remained normal, never went really low. So these two clinical pointers, clues, helped me to make a decision not to go inside the eye again. Just oral steroids was good enough, and remarkably, funnily, there was only choroidal detachment as one of the signs of inflammation progressing, and then because of the persistence of the oral steroids at high doses, that also disappeared. By week 3, it was completely gone. So in this case, I also had asked PB sir's opinion, and he said, orally we just discussed, he said, just continue the steroids, maybe it will work. And lo and behold, it happened. It disappeared. By 3rd week, everything was fine. It was an unusual case. It's a culture negative inflammation. I don't know what it is. I'm still scratching my head over exactly why it should happen this 3rd post-op day. 48 hours. Exactly 48 hours after surgery. Can't really blame even, say, posterior segment TAS kind of phenomena. So I'm not sure. Maybe there was something which even PCR did not pick up. So I don't know what it is.
This, when you talk about piece, gram and KOH, when you use a presentation, use a correct term, you cannot see growth on a gram smear and KOH. You see the organism where they are present or not. You are seeing no growth on a KOH. That's the second. First case, he presented with infection 13 days, if I remember correctly, or I miss?
Yes, sir.
Because something need to look into it very funny. Pseudomonas aeruginosa you are talking about. 13 days is very, very extremely unusual. They are so virulent. Okay, so very unusual. And if this is really, you got everything, culture positive, all those things, you can just write down that case report. If 13 days, unbelievable, you cannot have pseudomonas, you are waiting for 13 days to have it. Unless another incident happens, suture removal or something during that window, or something, another insult intraoperate, like something, a prick or something. It's otherwise very, very difficult to do. Like explain why it's 13 days.
No, but the suture removal was done after 3 days of.
No, I agree with that. Well, it's something else, some insult has to be there. Otherwise, post-surgery 13 days and that too pseudomonas is. I was looking at you may come up with a fungal or something the way you are narrating this thing, and suddenly when you clinical picture, yes, I would say clinical picture, I always will have the way a photograph you have shown. That's a suspicion, but 13-day window is somehow very not fitting somewhere.
It's not aeruginosa.
It came.
It's aeruginosa, it's another species.
No, it was Pseudomonas aeruginosa. So
But he is written Pseudomonas.
Could it be hospital acquired?
Yeah. This is the same time when even Madam had one same thing. Same time Madam also. This is also this is SFIL case.
Yes.
This fellow went to Kerala and came back.
Yes.
So when he came back, so that's what sir is saying. Some other insult has happened again. Pseudomonas cannot last for so many days and then suddenly one day it comes up. So something has happened. But Pseudomonas is also not an environmental organism. You can't get it from something floating in the environment, dirty water, whatever. Something has happened. It could also be from your eye drops.
Yeah. So one of my patients post-surgery, it's a simple VTL. I think he developed end of I think it was methicillin resistant staph or something. He was admitted, we gave the intravitreal and all, he was improving for 3-4 days, and then suddenly he started worsening. Then he got very severe infection with scleral infection, scleral necrosis, all the sclerotomy sites necrosis, exudative RD, very bad. And that turned out to be Pseudomonas. So I strongly suspect that it was hospital acquired infection because he was doing quite well. So anyway, now he's okay. The condition is improved and sclera is also good. Retina is attached. However, his vision is reduced a bit. Second thing I want to say is, oftentimes you see patients who are being treated with both antifungal and steroids. So you will see patients are getting vancomycin, voriconazole, and dexamethasone. So that I think is a little bit difficult to explain. Why would you give both voriconazole and steroid? If you suspect fungal, then you give antifungal, don't give steroid. And if you don't suspect fungal, then give steroids. But giving both together is not going to have any effect on the patient. So in fact, you are just increasing the toxicity. So be sure about what you are dealing with. And then if you are suspecting strongly fungal, then don't give steroids. But to give everything together makes no sense at all. And third thing is, when you give triamcinolone, in a case, sometimes the triamcinolone crystals itself will look like Endoph because that will be confused with vitreous exudates. So sometimes you will have patients who have received triamcinolone elsewhere, and it is like difficult to distinguish between vitreous exudates and triamcinolone. So preferable to avoid triamcinolone in Endoph.
So one thing is, I don't know whether the patient actually went outside and got checked for something. But that's the reason why we have this practice in SN that when we open a bottle, we use it the same day and throw it off. Okay, bottles which are kept open, used for multiple patients, has that risk because when you're putting the eye drop, many of times you're touching the lashes of the patients. We're doing something which is not right. And multiple people are using the same drops, wiping the drops. So, and saying we also wipe the AT. AT head is something which can easily transmit infections. That's the reason why we take these precautions with every patient. Whether they come at the first post-op day, whether they come at the third post-op day or fifth post-op day, when the eye is red and inflamed, that time please take these precautions because this is what can happen. Maybe at the time of injury, surgery, we never introduce an organism, but at the time of examination, we have exposed the patient to an organism. So that is the importance.
One question to Anand. He's left. No, because you made a remark about gram-negative organism and resistant to vancomycin. Would you expect it to be sensitive?
Gram-positive.
No, he said gram-negative. Gram-negative and resistant to vanco. So you would expect it, no?
Yeah, vancomycin generally, that's...
No, he made a specific thing that this was one of the 3 cases that had vancomycin resistance. But when you have a gram-negative or bacillus, you would expect a gram-negative organism. Vancomycin is not sensitive, no? I don't think you would call it a resistant organism. It is not expected to be.
This is there in the role of, I'm twisting it, role of steroids in fungal endophthalmitis? Have you come across any reference?
Sir, articles have shown, preclinical studies have shown worsening, sir. Whenever they have given, it is known to proliferate much faster and cause worsening.
In a clinical setting. Okay. So most of us agree that we do not want to use steroids in a fungal endophthalmitis. Yes, but you can have an initial infection or inflammation rather, I would say, can get masked with the steroids if you're giving. And then that can be sometimes misleading. And when you reduce the steroid dose, and then infection flares up, inflammation flares up, probably that gives another clue whether we are underlying infection we are dealing with. But there are 3 or 4 articles are there, L.V. Prasad group, and this one. There are a couple of more articles. They have shown that role of they do have some role to play. Basically, antifungals you are giving, and then you add steroid as well, so that curtail the inflammation. But yes, you are having along with antifungal. But that's just only 2 or 3 articles. Payman's group and Dr. Tara Prasad group. There are some 3 or 4 articles alone. But in general, just general consensus is just, and when you are dealing with a fungal infection, avoid steroid, avoid steroid, avoid steroid. That's it. Keep in mind.
Sometimes like post PK fungal endophthalmitis. So this means steroid they are giving, but in the low frequency.
So it's only topical, right?
Yeah, topical.
Topical can.
Yeah.
Topical we do give even otherwise. It's the intravitreal and the oral is what we will.
Sometimes 4 times
Once
dilution
infection is under
that you are
control, low dose you can give low frequency. Provided your organism is sensitive, it's responding.
Low potent, low dose.
Yeah.
So I had a couple of comments on your presentation. One is, I think you need to know what is subluxation and dislocation. So you cannot have sublux IOL and aphakia. By definition, subluxation means part of the IOL is still in the patellar fossa. When you're saying aphakia, then it's a dislocation, where it's gone completely into the vitreous. So you have to be careful of that. And when you're reporting an endophthalmitis in SFILs, I think it's good to talk about the suture or the haptic site, because that's the most common source of an infection. Not so immediately, but that is a potential risk for infection. Similarly, in the post vitrectomy nowadays, you also need to know, inform whether it was sutured or not sutured. Sometimes with the sutureless, so all these, and it also has an implication in terms of when you're giving an intravitreal injection or doing an AC tap, especially if it's not sutured, you would expect a little higher chance of leak from that point when you're giving an intravitreal. That's all.
We have one more.
Yes.
Thank you.
Thank you.
Yeah.
We are giving only 5 minutes now, unfortunately.
Good evening, everyone. The last topic for today's presentation is vitrectomy in endophthalmitis, and our moderators are Dr. Preethi and Dr. Vinata, ma'am. So we'll be dividing vitrectomy in endophthalmitis based on the 3 different types of endoph, which is post-surgical, traumatic, and endogenous. Before we get into the indications and the steps of vitrectomy, we'd like to discuss 2 studies, which is first one is the EVS, endophthalmitis vitrectomy study, which was a randomized controlled trial for post-operative endophthalmitis. They took 420 patients and divided them. This study was done in 1995. They took 420 patients and divided them based on the initial presenting visual acuity. When the visual acuity was hand movements are better, they did they randomized into vitrectomy versus tap and inject. And when it was light perception or worse, they went ahead with vitrectomy. What they concluded was that intravenous antibiotics showed no additional benefit. Immediate vitrectomy is of significant benefit in patients who present with PL vision. And when vision is hand movements are better, they found a vitreous tap and intravitreal antibiotics to be just as efficacious. What were the shortcomings of EVS was that the recommendation based on initial visual acuity may not always correlate with the severity of the inflammation. And the guidelines advised only at that time 20 gauge core vitrectomy for eyes with presenting vision of light perception. And they only had limited systemic antibiotic options at that time, and intravitreal corticosteroids were not utilized.
To counter the shortcomings of the EVS study, a new study this is an ongoing study, endophthalmitis management study. It is a randomized prospective trial. They have divided they made an inflammatory score based on the clinical features in the cornea, anterior chamber, iris, and the vitreous. Depending on the inflammatory score, if it is less than 10, they have advised for a tap to be done and intraocular injection of Vanco and Cefta, or vancomycin plus imipenem, depending on the initial culture and the smear positivity. Or if the inflammatory score is more than 10, they've advised for vitrectomy. And also in all the patients will be receiving the oral ciprofloxacin and intravitreal dexamethasone, which was not done in the EVS study.
Although the surgical management depends on case to case, we've tried to form a clinical protocol, starting with post-operative endophthalmitis. We would like to check the visual acuity of the patient, presence of hypopion, poor red glow and view of the fundus, and intense, well-distributed echoes on ultrasound. Based on this, we would like to assess the severity and chronicity of the infection and decide whether we would like to go ahead with tap and inject or AC tap as is followed here and intravitreal injection or early surgery. So surgery can be considered when there is no improvement after intravitreal antibiotic injections. So based on the clinical findings, what are the different surgical management considerations we would make? So if there is corneal edema in haze, although it might clear with after an AC wash, corneal scraping can be done later to improve visualization. We'd have to check for previous surgical wound leakage, and the main and side ports should be sutured in a case of post-op end-off. Anterior chamber can show either fibrinous exudates, or since post-operative endophthalmitis is more common in cases of eventful cataract surgery, there could be retained cortical matter, and the AC wash can be done via side port entry. Also, a needle infusion cannula can be placed into the anterior chamber or an AC Mentera when the infusion cannula cannot be visualized in the vitreous cavity. We will also have to check for IOL and capsular bag status. So in post-operative endophthalmitis, it's very common to have exudates over the IOL surface, and washing of the IOL surface is important. Also, the type of IOL is important, whether it's a AC IOL, iris claw lens, or PC IOL in the sulcus or the bag. And in case we are planning for IOL removal, we would like to anticipate difficult iris handling and bleeding. Also, since it could be an eventful cataract surgery, there could be capsular bag loss or tear, which we'll have to take care of. IOP can either be a hypotonous eye or elevated IOP, which has to be managed. So when would you consider IOL removal? In mild infections, IOL can be retained, although this again depends on case-to-case presentation, and in severe infections, removal is advised. In recurrent and non-responding cases, removal is advised, and for severe virulent infections like Pseudomonas acnes and fungal infections, IOL removal is advised. In cases where microbiology is available intraoperatively based on the virulence of the organism, also when the vitreous reaction is more of a reactionary echoes and the entire infection is around the IOL, IOL removal is advised in the primary setting. So the steps of vitrectomy in a case of post-operative endophthalmitis, the first thing is to give a very careful block and avoid massage. We can use either 23 gauge or 25 gauge, and the infusion cannula placement does not have to be necessarily in inferotemporal. It could be wherever the infusion cannula can be best visualized. Iris hooks can be used when the pupil is non-dilating. The first step is to collect an undiluted vitreous sample, avoid hypotony. Also, what we could do is check the connections before collecting the undiluted samples, because there can be a lapse sometimes there. The aim is to debulk the vitreous, and the endpoint, depending on the severity of the case, is visibility of the optic disc and the first order vessels of the retina. Vitrectomy can be extended up to mid-periphery safely as much as possible. Posterior vitreous detachment should not be actively induced, but if PVD is present, careful removal of the separated vitreous can be done. And a complete vitrectomy would only be advised if there is a retinal detachment that is pre-existing or occurs during surgery, followed by an endolaser and silicone oil tamponade as just appropriate during the surgery. And a watertight closure is very important with intravitreal antibiotics at the end of the surgery.
Coming on to a case of post-operative endophthalmitis. She is a 74-year-old female hypertensive. She underwent cataract surgery on 26th of March and presented to the emergency department 3 days post-operatively with complaints of pain and redness in the eye. As we can see on post-op day 3, she had intense conjunctival congestion along with corneal edema with a small hypopion. The visual acuity at that time was hand movements. We did an ultrasound which showed vitreous echoes, which was more in the posterior, more close to the retinal surface. So an AC tap was done and intravitreal injection of Vanco, Cefta plus Deca was given. The aqueous aspirate, it showed Burkholderia capaceus species was isolated in the culture, which was sensitive to ceftazidime. So she was intravitreal injection was given. She was re-examined on the next day. There was no increase in hypopion, and the vitreous echoes were also similar. But as the patient was very scared of intravitreal injection, she was given an option of vitrectomy. So on post-op day 4, post-op day 4 of cataract surgery, she underwent vitrectomy with intraocular antibiotics. She was doing fine. This is the post-op day 3 image after the vitrectomy, showing clearing of the hypopyon and clearing corneal edema. However, on post-op day 12, she developed a trace hypopyon again, and she was a repeat intravitreal Cefta and Dexa was given. She kept on getting AC inflammations. Whenever we tried to separate the injection, whenever we tried to increase the duration in between the injections. So, and again, after 1 month post vitrectomy and multiple intravitreal injections, she was again presented to us with the hypopyon and increase in the corneal edema. So she was planned for IOL explantation. The IOL explantation was done, and intraocular lens was sent for microbiology. And in this also the culture revealed the same organism, Burkholderia sebaceous was isolated in the culture. This is the photo showing the post-op 2 weeks post IOL removal, which showing a clear cornea and clear AC with good view of the fundus. Vitreous is clear.
In a case of post-traumatic endophthalmitis, we would consider immediate vitrectomy as the organism spectrum is wider with more virulence. And it is important to look for retinal detachment and intraocular foreign body in a case of post-traumatic endophthalmitis. Additionally, when we are taking up the patient for vitrectomy, it will also help clear any retained lens cortex, vitreous hemorrhage, and treat any retinal breaks. So again, clinical features that we would expect in a case of post-traumatic endophthalmitis and the surgical considerations we would have to do for that. First is to check the injury wound, whether the wound is open or it is a previously sutured wound. So in case the wound is open, either a primary wound repair and vitrectomy can be done in the same sitting, or a wound repair followed by vitrectomy in a staged approach. If it's a previously sutured wound, it might need resuturing or suture removal of the loose or exposed sutures. Cornea can have a tear, suture, scarring, or haze, and that's why in cases of post-traumatic endophthalmitis, it is important to keep a PK backup, and vitrectomy can be done with a temporary K-Pro, which is advisable, or open sky. Anterior chamber can have hyphema, fibrinous exudates, and retained cortical matter, so AC wash is advised. The lens, the patient can either be aphakic with a clear lens, where vitrectomy can be done directly. If it's in case a ruptured or a dislocated lens, cataract extraction or pars plana lensectomy can be done. If in case there's an IOL, we try to avoid IOL and bag manipulation during vitrectomy. The IOP also has to be managed. So again, the vitrectomy in a post-traumatic endophthalmitis case would be similar to how we discussed in a post-op endoph case. And only central core vitrectomy to go close to the retina, and no base dissection and no peeling of the posterior hyaloid face. And also at the same time, during the surgery, we would have to look surgically consider if in case there's a choroidal detachment, a suprachoroidal hemorrhage, foreign body, vitreous or retinal incarceration, and retinal detachment, and the surgical technique will have to be modified accordingly. So this was a case of a 36-year-old female post-LASIK. She had an injury with pen 10 days back and presented to us after a corneal tear repair. A vitreous tap was done outside, which showed a Streptococcus sanguinis species, and she was on topical fortified vancomycin, ceftazidime, and Predfort. On presentation, her visual acuity was hand movements. She had a sutured corneal wound inferiorly with some exposed and loose sutures. Fibrinous reaction in the anterior chamber with a small hypopyon and exudates over the anterior capsule of the lens. The ultrasound showed dispersed, dense, low to moderate reflective echoes with incomplete PVD and an attached retina. We took her up for right eye corneal resuturing with a 25 gauge vitrectomy and intravitreal antibiotics. And the culture that was done here showed no growth. On post-op day 2, she was improving. The vitreous cavity was clearing with peripheral uncut gel that could be seen. And by post-op day 10, her AC was clear with a good view of the fundus. She had some barraged lesions in her eye, and the in PVD edge could be made out inferiorly. She's currently at 636, doing well.
Coming on to endogenous endophthalmitis. So mainstay of treatment involves systemic evaluation and management with the infectious disease specialist opinion is to be sought. A thorough clinical examination along with the examination of the other eye is important is endogenous endophthalmitis as it can be bilateral. The purpose of the vitrectomy is to debulk the vitreous exudates and requires a careful dissection as the retina is more friable due to the presence of retinitis and choroiditis. Coming on to a case, he was a 25-year-old male patient, presented with complaints of floaters since 20 days. He was treated elsewhere first as panuveitis and then diagnosed as endogenous endophthalmitis, underwent an AC tap which was smear negative, and 1 dose of interval antibiotics was given. There was no history of fever, vomiting, urinary symptoms, IV antibiotics or IV drug usage. On presentation, there was corneal edema along with a thick hypopyon in the anterior chamber with the pupillary fibrin membrane in the pupillary area. The ultrasound shows plenty of, it is full of vitreous exudates which are moderately reflective. The retina was attached. He was planned for lensectomy along with vitrectomy. Systemic evaluation was done. He was evaluated for the viral markers. Blood culture and urine culture was sent, which was turned out to be all negative. He underwent lensectomy and vitrectomy. Vitreous aspirate was taken, which was PCR for the eubacterial genome was positive, and gram-negative bacilli was seen on smear, but the culture did not really reveal any organism. An ID specialist opinion was taken, and he was started on IV meropenem 1 gram TDS. Post-operatively, we injected with the intravitreal antibiotics. However, on post-op day 5, ultrasound was suggestive of retinal detachment. But still, the cornea was very hazy, so we deferred the further surgery at that point of time. After 10 days, around 10 days after the primary surgery, he was taken up for retinal detachment surgery. This is the post-op picture showing a clear cornea and attached retina under oil with the drainage retinotomy which can be seen nasally.
This is a video by Dr. Sia sir. It shows the exudates that can be present in case of end-off and how we clear them. So in this case, he's already done the core vitrectomy and there's a cast of exudates all over the retina. There was PVD present inferiorly, so he's trying to clear the exudates inferiorly and go slowly as much as possible. There are 2 more studies, that is the complete early vitrectomy and the roll of silicone oil, which is not normally practiced here. A different school of thought, but we just thought we'll include them because we came across it. The complete and early vitrectomy said that it's better to clear off everything because the purulence in the cortical vitreous is the cause for vision loss. Since in EVS, maculopathy was the cause for vision loss. So they advised complete and early vitrectomy. And in the silicone oil study, they said that silicone oil is associated with better visual acuity and lower rate of retinal detachment since it has antimicrobial properties and produces compartmentalization. But the disadvantage is that it could cause more toxic effects on the retina and the optic disc and impaired washout of the pathogens. These are our acknowledgements. Thank you.
So I just wanted you to also highlight the importance of placing the sclerotomies, or rather starting from the first thing. Like she said, local anesthesia. Kindly tell your anesthetist or when you give it yourself that if it's a recently operated case, because I had a lot of surprises by the time I got ready for the case. Well-formed AC had become flat. The wounds open up. So always be careful to tell them or when you give it yourself not to do massage. And in all these recent pseudophakic end-offs. Then another thing is placement of the sclerotomies. Don't hesitate to place the sclerotomies in the infranasal quadrant or anywhere suitable where you would be able to see it. Do not think that you have to place it in the okay. Let's speak up. Okay. So, in a trauma case, in a pseudophakic case where the the corneal entry is there, so accordingly you check and you can place your sclerotomies. And better to keep it more anterior because you're going to have, meaning if it is 3, you do not hesitate to even keep it at 2.75. Since you will have a lot of exudates more in the pars plana and this. So it is always to avoid going through either choroidals or the ora. Just try and do it slightly anteriorly if it is pseudophakic. If it is phakic, yes, one has to plan. Always don't hesitate at the end of the surgery to close it even by opening the conjunctiva because you will have lot of this bleeding, congestion, chemosis. So, and you will think it is closed. So, better to open the conjunctiva, close it, and then be very meticulous in the closure. And one more point which I practically had faced is they say when you give a vitreous sample, it should be undiluted. So, the normal practice would be to directly go in the eye and do, but many a times it's done in the night, it's done with the older instruments. So I feel always it is better to check the cutter outside with the fluid, and then with a sterile syringe you empty the whatever you have. While checking whatever fluid you have sucked, you can empty it from the cutter, make it dry, take a new syringe, and then now go in and take the sample. Because 2 of my cases when I had done with undiluted inside, recently done pseudophakic, and I had planned to retain the IOL, but when this cutter was connected wrongly, and I went in, we cut, we had the IOL coming out because it builds up the pressure inside. So after that one episode, I learned always to check it outside and then go in and do. Even if it little bit of fluid remains inside, it's better than not checking it. So these are just some of the practical points I wanted to tell.
No, anyway, cutter, we are supposed to always cross-check that connections are correct. So otherwise you are pushing air inside, and that can be disaster in any situation, not only endophthalmitis. What happened, unfortunately, I mean, a good thing you brought that point. Particularly, we have OT newer sister assisting quite some time. They do not check. Same thing with the cautery or cutter. The out of context of this, but that's a good thing you brought it. As a routine, all the instruments should be checked outside before taking in. One part. Second, if you are taking a sample, what we dry, I mean, an undiluted sample to avoid already hypertonous eye, to minimize the risk of hypotonia, globe collapse, and then sometime IOL dislocation, what she said. Another easier way is, you don't want to turn the infusion on, don't want to turn the fluid on. Probably you can have air on to start with, but not high pressure. So air going in, so that's what practically, yeah, theoretically you can talk, you are contaminating or other things, but expected operation theater air is clean. So you can, that way, you maintain the pressure as well as you can collect your sample. Okay. Yes, air will cause some amount of visual disturbance to start with, but once you restart the fluid, you can remove the air and continue with the procedure, but you still will be able to get undiluted sample for your microbiology purpose. As far as possible, because we know these eyes, I mean, recently operated, and when you have obviously inflammation and orbital inflammation involved along with that and edema, generally local anesthesia most of the time doesn't work. They will have some amount of pain. So given option, always do not hesitate to ask for GA, rather ask for general anesthesia. And if anesthetist says you just cannot give because of the systemic issues, then fair enough, you do not have choice. But by choice, ask for GA, not for local anesthesia. I just have one question though. Your first case you are talking of, like, no, leave it that way. You says when corneal edema is there, you want to scrape the corneal epithelium. You are talking about surgery or to see the fundus?
Surgery, sir.
Surgery,
that was the
okay.
surgical considerations.
Okay, that's fine then.
if the corneal clarity improves with AC wash and if you're able to visualize the fundus like that, it's fine. But in case intraoperatively it's required, corneal scraping is an option.
Yeah, that's fair enough. As far as possible, we definitely avoid PK, but quite some time that fibrin, if you have, which looks like as if corneal haze, sometimes that membrane, the moment you remove, everything becomes so clear. IOL also, there's no need to remove. Cornea also is clear. And the other case, second case, probably fibrin-like thing, we said like a membrane cover on the cornea, and that wound repair was done inferior part. In fact, that looks like a fibrin already contracting, responding well. I would have waited, probably not rush for vitrectomy in that case. So you see like those crenating edges, it looks like more like already contracting fibrin rather than active endophthalmitis. And you said patient was being treated, organisms are already identified. Probably that's the reason you could not get. But looking at the picture, probably that looks like as if patient is already responding.
Anyway, taking up the case for corneal resuturing, I think. That's why. But I think I still have reservations doing corneal scraping in an endophthalmitis case because you're opening a chance for a keratitis setting in. As far as possible, just try and do the corneal detergents with the kuchi. And here you're not looking at a very absolute crystal clear view. Your aim is to do a core vitrectomy, get the sample, and also get space for the antibiotic to go in. So as far as possible, try and avoid doing that. Another point against the silicone oil is, despite all its advantages, it tends to push the peripheral vitreous against the retina. More than the retina, the ciliary body. And you will have a clear vitreous, but you will have a patient with a hypotony because of the peripheral membrane. So if you're doing a silicone oil, you should be ready for an early removal also.
The problem with that, when they are recommending silicone oil, but what you rightly mentioned, it's recommended that do a thorough vitrectomy, remove everything. The logic there is, apart from what you talk about antibiotic, that residual vitreous, left vitreous will later on fibrose, can lead to contractions, traction on a ciliary area, detachment, then hypotony. Okay, or that contraction can lead to tear, peripheral tear, and then RD, delayed onset. But we need to also understand this is inflamed retina. And when you inflame retina, you try to do like thorough base excision. Have extremely high incidence of creating break right on the table. So most of these eyes, you will end up creating a lot of breaks, peripheral, and then they do 360 laser and then fill with the oil. So you are compromising it to start with only. Okay. So, and which is, we realize with the experience, which is not necessary most of the time. So bare minimum necessary. Not cutting corner, but at the same time, don't overdo. Avoid any complication on the table as far as possible.
Any more questions?
Thank you.
Thank you.
Thanks. You wanted to ask me. Thank you. Thank you very much. You wanted to ask something.
So good luck once again. All the best for your future plans.